asking unnecessarily quite a lot of tests. So that is the thing that more and more centers need to come up. And the cost of post-transplant, immunosuppression is fortunately for us really come down because we've got good Indian companies at par with the international standards. And the immunosuppression is now 43 rupees for a tablet, and Indians are really lucky because the requirement of immunosuppression is much less than the people abroad. Like I have Africans, 7 of them or 6 of them, they require 5 or 7 times the dose of an Indian child.
Okay.
So we are lucky. The cost is coming to me in an Indian child 100 to 150 rupees a day.
Okay, so that's Girish. Are you going to say that you're going to come back to India because what you heard, Neelam, many centers and it's going to explode? That's not allowed.
Okay, no, Maya. I think one of the ways of reducing the cost would be what you have stressed before: an early referral for transplantation. Because if you transplant a child in a well state, that child's costs are definitely going to come down. Because the hospital stay is going to be better, the post-operative outcome is going to be better, and that's something which we all really need to look into.
Yeah, I think that will be a great message to end this session with, because we need some time for questions. So I think I'm going to end here. I think that's the critical message: early referral, timely referral. It's available now for a small subset of the population. That's what I thought we should cover, but I'm sure there are questions, responses. Another 5 minutes, 10 minutes, we can take them.
What I plan to do is not to consider febrile children with liver and spleen who obviously have no suspicion of liver disease. For example, I'm not discussing malaria, calas, or leukemias and whatnot. But I would restrict my discussion to febrile patients where there is a hepatosplenomegaly and the suspicion of some liver involvement. So to begin with, we will restrict our discussion to only that kind of a group of patients. I would go about citing the live case scenarios to make points of how a clinician should approach to make a final etiological diagnosis of a liver disease in a child who has had fever. And I think we have done this before, that when I see a child with fever and hepatosplenomegaly with a suspicion of a liver disease, I need to be sure which part of the liver is involved, because the etiologies would be different. And then I also like to remember that fever doesn't mean infection alone, but fever is an indicator of inflammation, though commonly it could be an infection, but it could be an immune-mediated inflammation, or it could be just an infiltration and a cell damage which causes a pyrogenic reaction. And therefore, when you have a fever, you probably have a vast variety of etiology of groups beyond infection and immune-mediated and also an infiltrative disorder. Having said this, we would naturally anticipate a combination of the first 4 sites of microscopic liver involvement anatomically and the 3 types of inflammation that would cause fever, and therefore you would have many permutation and combination of this kind of a situation, and we will see how the things go further. I would also like to elucidate examples where it might look something very simple, but it might be a hidden complex situation which resembles very simple infection, and I'll just go about with such case scenarios. I think it is very easy to spot out a liver disease in a febrile child when he presents with acute onset fever with hepatitis. Majority of these children come with a small duration of illness, and obviously they have symptoms and signs of hepatitis, but it's important for a clinician to pick up an etiology of hepatitis in such children. This was a child who came with 8-year-old fever and jaundice of acute onset. When an 8-year-old child comes with acute onset of fever and jaundice, the common etiology in our country being Hep A infection, but often one tries to forget that many times a Hep A infection has a prodrome of maybe a nausea, vomiting, loss of appetite, whatnot. This child presented suddenly with a acute onset. Jaundice increased very rapidly within a day, and by the end of 48 hours, this child fainted, which was considered as a seizure. By and large, I don't think an acute febrile child with hepatosplenomegaly presents with seizure anytime. And to that extent, this obviously looked something different. Physical examination showed a very deep icterus. The liver was large, tender, and there was a significant pallor. The child was very, very pale. This would naturally take us away from a simple AP infection. And when you saw this child, this was obviously a Wilson's disease. We all know that Wilson's disease can come with an acute fulminant liver failure, and this child exactly presented like that. It was very clear that this child worsened very quickly and had a very significant severe pallor as well, and a combination of these two. Autoimmune hepatitis may also have an autoimmune hemolytic anemia, but not this kind of an acute fulminant episode, and therefore it certainly looked different. This child obviously required an immediate liver transplant, and this child is all right now 2 years down the line after a liver transplant. This was another similar looking child who presented with fever and jaundice of acute onset, but he also complained of knee joint pain. There was obviously something different in this child. He had a tender hepatomegaly, he also had a skin rash, and he had a mild knee swelling. Naturally, this was a prodrome of some autoimmune disorder with a skin rash and an arthropathy. And a point that I want to make is that while it looked like a simple autoimmune hepatitis, which obviously would need some more confirmation, preferably by a liver biopsy, but by then when we looked at the antibodies, antibodies were negative, ANA was negative, but the point to note was this child had a family history of consanguinity, and finally this also turned out to be a Wilson's disease. I'm sure most of the hepatologists would tell us that Wilson's could manifest also with an autoimmune phenomena, and this is just to bring out that what obviously looked like an Hep to start with in the first child was not a Hep A, and what this looks like an autoimmune hepatitis may not be an autoimmune hepatitis. And again, a point to make that many times you need some more confirmative evidences and not just go by what the serology or a biochemistry probably tells us. This child is a little different. This child develops fever for 6 days and a jaundice appears later. First two children develop fever and jaundice almost simultaneously, and this child obviously had a different progression. And then we know this obviously that this is a child who has got very likely an extrahepatic infection with a hepatitis as a complication, and I'm sure most of us as pediatricians see this very, very commonly in, say, typhoid or a malaria and so on. Rarely one has seen even a leukemic hepatitis come very similar, but I'm sure leukemic hepatitis per se is extremely rare. In our situation, it would be a typhoid or a malaria, but it's so easy to pick up for a clinician because these children do not come and present with jaundice and hepatitis, but somewhere down the line they develop as hepatitis disease. This is another one who starts with fever for 5 days. He's treated with antibiotics hypothetically. He gets better, and then the fever relapses. And then at this stage, he develops jaundice. The first child develops jaundice right through fever. This child apparently gets better and then develops jaundice. Obviously, he's something different. He has an icterus, a liver and spleen, and he has a biphasic fever. It's important to pick up that he apparently got well and then he got worse. Many times these children with biphasic fever had a second immune phase, and that immune-mediated complications may come with hepatitis, renal failure, or whatnot. And this obviously looked different than a typhoid hepatitis, where a hepatitis almost merged with presence of fever, and this child got better and got into another immune phase, and this turned out to be a leptospirosis. Well, this was another one who was a younger child, who also got fever for 4 days and got better. Again, a biphasic kind of a fever, but then this time he doesn't develop fever like the first child, but develop lethargy and abdominal distension. I'm sure all of us as pediatricians look at such children who develop lethargy almost at the time when the fever is disappearing, have some kind of a complication like an immune-mediated capillary leak, and this child certainly did have shock. He had a hepatomegaly, he had a mild ascites, pleural effusion, icterus, etc. This child therefore behaved differently than leptospirosis, where a biphasic fever ended with a complication which was immune-mediated. And this child, when the fever was getting recrudescence, developed another immune-mediated complication of a capillary leak, and develop this. Well, this is not directly to my mind a viral infection like a dengue, but probably a point to make is that besides the infection, the complications that arise like a circulatory failure, a shock, hypoxia, metabolic, therefore derangement, also would affect the liver and present like a hepatitis. And these children may not have a viral affection of the liver, but similarly presenting because of hypoxia, hypoxemia, and a capillary leak. And therefore, this is something that we often see in our situation. Well, I think having shown these children with acute onset fever and jaundice, but some of them presenting together, some of them following fever and then jaundice, some of them getting better with fever and then developing jaundice. These are the syndromes of acute onset fever with jaundice. What about acute onset fever without jaundice? These are the children who present with a significant abnormal liver, abnormal to feel in terms of often firm liver, which obviously means that it's some liver disease. And let's see how this 6-month-old infant came with fever of acute onset, and in examination he was looking very healthy. He had an abdominal distension, he had a liver, he had a spleen, he was tachypnic, and he had a scattered crepitation. Obviously he has a respiratory disease, and along with that he probably has an abnormal liver and a spleen too. Obviously this is a disease of infective origin which has spread beyond a respiratory tract into the liver as well. And important point to make again is that it's not enough to say the liver is enlarged and palpable per abdomen, but it's very important to pick up a liver span. And unless the liver span is increased, you don't call it a hepatomegaly just because the liver was looking large per abdomen. This child obviously had a genuine hepatomegaly, and this child had a miliary tuberculosis. Again, we all see this not uncommonly. These are healthy looking children who don't have a long-term chronic symptomatology. They present with an acute fever, but certainly they have obviously a pathology which is systemic, spread out infection, and you have a diagnosis of a miliary TB. Obviously you have a contact, you have an x-ray which might show a miliary, etc., and only rarely you would need further investigation like a liver biopsy to pick up a tubercle there. But this was another one where a 6-month-old child came similarly with fever of acute onset. Physically he looked very healthy. He also had an abdominal distension. He had also similar situation what last time we saw the child, and looked very similar. I think a good physician would pick up this liver to be soft and therefore get a probability that this liver is not abnormal or pathological, and then you looked at the liver span and the liver span would be normal, and this obviously is a push down liver in an acute bronchiolitis. Both these children may look very similar if you look at them superficially, but if you get into the depth, there is easy way to find out whether the liver is abnormal. One, by a liver span showing hepatomegaly genuinely, and then of course the feel of the liver. And I'm sure majority of us, having gone through a training period, call a firmish liver or call soft to firm liver so that you can be on either side of the examiner. So I think this is the way sometimes a child may fool with a liver disease, and this child had obviously no liver abnormality, and it's important that every time you pick up a liver span. This 8-year-old child came with fever for 3 days and body ache, headache. Fever was less on day 4. This was an obese child. By the time we saw this child was on day 4 of fever, getting better, but had a liver which was obviously firm, rounded border, not tender. Spleen was not palpable. Obviously we are taught that whatever you see in the history and physical examination, you try to correlate into one diagnosis, but not always essentially, because this child has got a firm liver which is not tender, this child is otherwise all right. So obviously it looks like some chronic liver pathology in a child who has an acute onset of fever. Obviously this is an unrelated fever, and this child had a fatty liver, he is an obese child, he has got mild enzyme raise, and therefore many times you would see a silent liver disease in which a patient manifests with some unrelated febrile condition, and one has to really see how you split out an acute onset of fever different from a chronic silent liver. For example, another example of such a situation is a metabolic disorder. I'm sure Ashish would know that many liver diseases, metabolic liver diseases, would be brought to a pediatrician with some subtle onset of fever viral, unrelated, and you develop a jaundice and you try to correlate the two, and you know that there have been a silent biochemical abnormality which had nothing to do with an acute onset of fever, and the fever would disappear. Well, rarely you get fever prolonged with jaundice, and this was an 8-year-old with a fever for a long time. He had a large liver, a mild tenderness. He had an engorged neck veins. The point to make is that it's important when you get a large liver to look at the engorged neck veins, because that only gave you a diagnosis of a constrictive pericarditis. Otherwise, you would go on fishing for an apparent liver disease, and you might even do a liver biopsy because you had a hepatomegaly and a firm liver. So I think the point to make is every large liver must have an engorged neck veins to look at, and it's so easy for a clinician not to miss it. And lastly, this was another one who had a moderate pallor, liver and spleen, but he had an abdominal mass to guide you. And obviously when he had an abdominal mass, a lymph node mass, you knew that this was probably a Hodgkin's disease. And therefore, to that extent, I would just end up by saying that when you have a clinical approach to fever with hepatosplenomegaly, look at acute onset of fever with jaundice present together. You have a hepatitis or a cholangitis. If you have a jaundice following later after some due to the fever, then you have a complicated hepatocyte involvement. If you had a prolonged fever without jaundice, very likely you had a reticuloendothelial cell involvement or a systemic infection. If you had a prolonged fever with venous obstruction, you probably had a constrictive pericarditis to look at. And at times, you may have a fever unrelated with pre-existing silent liver disease, and two have nothing to do with each other. And at times, you have a push-down liver, which is not a liver disease at all. Thank you very much.
Good afternoon, everybody. We have a panel discussion on constipation. The panelists, most of you are familiar with Dr. Shobna Bhatia, and then, if I am correct, Dr. Karmarkar, and then Professor Jhankaria, then Sandhya, and then Rajesh. Is that right? Let me have a feel. All of you have the same functional constipation? How many of you are using polyethylene glycol to treat functional constipation? All of you? None? Yeah, many of you. Good. I will start with the case. And Dr. Karmarkar, among the panelists, I think you are the person who is handling maximum constipation cases, I suppose. Because in our pediatric practice, constipation goes to surgeon, because all of us have the feeling that we should not miss Hirschsprung disease. So I will take your help in analyzing the case. So maximum question will go to you. This is a 3-year-old girl we have seen, came with a complaint of passing hard stool once in 3 to 4 days for the last 6 months. And she also had encopresis once or twice per week. Her stools are absolutely hard, like a stone, large in quantity, associated. Whenever she passes, she cries. And there is history of face bleeding per rectum. It is mainly streaks the stool once in 2 to 3 weeks. So, sir, Dr. Karmakar, what are the other relevant history you would like to ask this child who has come with a stool, hard stool, passing once in 2 to 3 days?
This duration of the history is from 6 months.
6 months, yeah.
So I'll confirm that there was.
No, sir, I said it is a 2.5 years onwards. It's last 6 months she is having problem.
Yeah, so only for 6 months.
6 months, yeah.
So we'll confirm that the history is definitely only in these last 6 months and not since earlier.
Right, right.
And then, of course, if need be, we can ask about history after birth, whether there was delayed passage of meconium. But one thing which I definitely like to ask is dietary history.
Yes.
I think most such cases of acquired functional constipation in our practice, in my practice, are most of the times dietary, and sometimes surgeons don't tend to ask about that at all. Plus, many of such cases we need to know whether they are bottle fed.
Exactly.
And persistent bottle feeding is again something I have seen to be a cause of chronic constipation in this age group. And I follow a policy of not talking to them further if there is a history of bottle feeding unless they stop the bottle feeding habit. In fact, if somebody rings me up with these complaints and on the phone I ask them, is the child bottle fed? And if the answer is yes, I say, please don't come and see me till you've stopped the bottle. So these are some of the things that I will ask, plus the others that I think have come up.
You talk of this, I think it is very important to ask about delayed passage of meconium, and very interestingly this phenomena is noticed, that retentive posturing or withholding maneuver, that parents will tell you that my child is trying hard to pass stool but he can't. So that is basically the other way around. This child is trying hard not to pass stool, and they make this scissor-like movement. They crisscross their leg and try to withhold. In pediatric practice, sometimes the drugs can cause constipation, like anticonvulsant, etc., etc. Very importantly, diet. I endorse your view that this is the milk. These kind of children, they are predominantly on milk. There is no weaning diet at all, and you need to know about neurodevelopmental delay can have constipation, associated failure to thrive, etc., etc. This child history is born to primary gravid mother, full-term normal vaginal delivery. She passed meconium on day 1, so there is no delayed passage. She was breastfed till 5 months, and then what you said, sir, predominantly on milk. Every day she was gulping 1.5 liters per day with bottle, no roughage at all. Developmentally normal, there is drug history, she was given lactulose by pediatrician, taken 2 weeks, improved, mother stopped, constipation recurred. And this is the history we get often, the posture of the child during defecation. She passes stools in standing position, she doesn't want to sit, she screams while passing stool, she tends to hide behind a curtain, does a crisscross leg movement, moves her pelvis to and fro. So it is, mother interpretation is that my child is trying hard. Actually she is trying hard not to pass stool. So this is a very important history if you get, that goes in favor of functional constipation. Examination finding, anthropometry normal, no pallor, neurologically child is normal, spine is normal. Sir, Dr. Karmarkar, what will you look for in the abdominal examination, including bottom?
If it's a case of acquired functional constipation, usually in the abdominal examination there will not be huge distension as one would see in cases of congenital constipation. So I wouldn't expect the abdomen to be huge and distended. However, because of the chronic nature of constipation, there will be fecalomas which may be felt.
Yes, sir.
But this abdomen will not be like the Hirschsprung's abdomen, a large pot belly kind of. And overall, the size of the abdomen will look quite normal as compared to the remaining body. So that is, and we may see fecalomas.
Sir, I want you to emphasize this point.
Yes, in these kind of cases, you will find that there is hard stools right up to the verge, right up to the anal verge. And depending on how many days the child has not passed stools, it may be hard fecolids with maybe some degree of a fissure may be there which may cause some bleeding.
Right.
One point of which I want to mention here is very rarely there can be a variety of congenital constipation which can have stools up to the verge, and that is what we call as the ultra short segment Hirschsprung's or the internal sphincter achalasia, and that is one congenital problem which may manifest with hard stools up to the verge.
Just like functional constipation.
With hard stools up to the verge.
Yes, sir. Yes, sir. So we agree this abdomen was absolutely soft, no distension, what Dr. Karmarkar has said, but there was fecalis palpable in the left iliac fossa. And simultaneously, as a pediatrician, you need to look for any neurological abnormality, like buttocks are symmetrical, asymmetrical, signifies some neurological problem. Anal opening position, whether it is anteriorly located or not. Reflex, the anal reflex, you give the stimulus C, whether the any neurological problem. Sphincter tone, obviously you do, and PR is very important. Ma'am is since morning telling that in pain also you should do PR. So PR examination is a must in it when you examine a child with constipation. That will give you maximum information. The hard fecal mass in this child, and there is no one point that you withdraw the finger, gush of fluid comes out in Harspang, which was not there in this case. Dr. Sandhya, clinical impression is very simple, clear cut, isn't it?
Functional constipation.
Yeah, right. Functional constipation in view of onset early, it started after infancy, around 2.5 years, the time when you are supposed to transit from liquid to solid. They don't do it properly. See, this baby passed meconium on day 1. There was associated withholding or retentive posturing. History of encopresis and bleeding pair goes in favor of functional rather than congenital megacolon, and parectal examination showed full of fecal matter, and there was no apparent neurological abnormality, inflammatory or metabolic blah blah causes. So this fits with functional constipation. Dr. Karmarkar said, what will you do? Will you investigate this child, or you will start treatment straight away?
Well, I won't investigate this child very specifically. I mean, there may be some general tests which you may want to do in a chronically constipated child, maybe anemic, so you may want to know his or her hemoglobin, etc. But from a surgeon's point of view, I would not do any specific tests, and which may be a red herring and take you into some different direction.
Yes. We are having altogether different ambience now in the morning. We have a lot of firewall between physician and surgeon. Now surgeon is totally with the physician. Dr. Sandhya, do you agree with Dr. Karmarkar? He's a senior pediatric surgeon.
From the pediatric point of view,
Yep.
because the diet is mainly milk, they are likely to be iron deficient.
Yep.
They may be, so you may want to just do a basic blood count. Depending, some people feel that if it's the first presentation to a pediatrician, then they should have baseline thyroid function done as well.
Okay.
That's still a controversial, but apart from a blood count, I personally would just see if the child's growing well. I wouldn't even worry about that, because the treatment is iron, which is going to make them more constipated. I'd want to treat the constipation first. So no test.
Right. This is the actually algorithm postulated by North American Society Pediatric Gastroenterology and Nutrition in their position paper. This child is more than 1 year. What Sandhya is highlighting about thyroid profile is more important to rule out that in an infant when it is coming with constipation, and you are worried about Harspang in infant, and if it is a more than 1 year, you are less chance of having thyroid. So they said that history and physical examination is enough to make a diagnosis of functional constipation, and you decide if there is a fecal impaction like this child having fecolis palpable, PR full of feces, then you have to do probably disinfection first and then maintenance therapy and then observe. Okay, the reassessment is important. If this child is not improving on your regular therapy, then you look for other causes like blood test for thyroid, lead poisoning, celiac disease, rule out Harspang, etc. etc. Sandhya, the management protocol for functional constipation, just a brief outline. Disinfection followed by
the child needs disinfection. His rectum's full of hard feces, so you could pour in a high dose oral laxatives. It's just going to bypass and cause overflow. So the way to disinfect, there are two thoughts, both of which are reasonably effective. One is the use of enemas. Now, in the Western world, people are more reluctant to use enemas. I'm not sure what the state is in India. But with the preparation of pegylated glycol now, one can use disinfection. There are two ways. One is the clean prep preparation, which requires admission to hospital, nasogastric tube, and pouring 3 litres of a glycol type preparation. Or the other way is to actually use Movicol, which the parents then give, and you would then have to give, some people go slowly, work upwards. I prefer high doses for 2 days and then reduce by 2 sachets per day. So you would start for a 2-year-old, 6 sachets daily for 2 days, then 4, then 3. I find, however, that for disimpaction, if you don't use an enema, it just takes much longer. because the fecalists have to break down. But the importance is once the disimpaction has been done, the child will need maintenance treatment, and to explain to the parents that not to stop the medicine as soon as they think a stool is starting to be normal. In the olden days, it was a step up. You start with a bit of lactulose, which is a stool softener, and then you use a stool stimulant. I think nowadays, with the newer preparations, we're often bypassing those because you can use Movicol for maintenance treatment as well.
Our index patient, we have done what Sandhya said, that disimpaction, but what we practice, the smaller kid we admit, because it is very difficult to do disimpaction at home. You give the prescription, they will not be able to give that quantity of polyethylene glycol solution. This child will vomit. So what we do, we put a nasogastric tube, we give a dose of perinum, and then we give this infusion of polyethylene glycol solution 25 ml per kg per hour till the output is absolutely clear. Okay, this is the protocol we follow. And after that, we are doing a study randomizing polyethylene glycol versus lactulose. This child was on polyethylene glycol. We have given dietary advice to decrease milk and increase roughage, and simultaneously toilet training. Sandhya, already you touched upon about this disinfection with enemas versus polyethylene glycol. How effective is the home-based disinfection? Because that you practice probably. Is it
in the young infant? I also would admit to hospital, use a nasogastric tube and clear them out. In the older child, the traumas of putting an NG tube down and having the fluid. So we're finding that using the oral high-dose Movicol, it depends on the parents. If they really understand the issue, they will enforce it. We are strict, we'll make sure they don't have fluids only for the first 24 hours, and then only jelly for the second 24 hours, and then they're allowed to eat. And I would say that one has to do it on an individual basis, judging on the family, but the younger ones, we admit.
Yep. And we had this impression that though the enema is very effective, in adult practice you give enema and do the bowel cleaning, but in children, especially functional constipation, Dr. Karmakar will agree with me that the main problem is the pain. They have a fear of passing stool because they had it in mind, if I pass stool then that will hurt me. So that's why they don't want to pass stool. So the pain is the basic problem, and you put a catheter into the rectum, that will aggravate this problem. So though it is a very effective, faster mode of disinfection, but it is invasive, likely to add fear and discomfort. So we try to avoid. But very interestingly, there is a study published recently from Netherlands, and they have compared this enema versus polyethylene glycol, and they said both are equally effective. So you can do it with enemas also. This is the only one word study. We may not agree with it. Sandhya, after disinfection, you will start on laxative. So which one do you prefer, lactulose or polyethylene glycol as a maintenance therapy?
My personal opinion is lactulose is useless. So
is there any added advantage of polyethylene glycol over lactulose? It is both are equally effective.
I disagree with that.
Okay.
With the pegylated glycol, I think that the way the pegylated glycol works, it's a more effective medication than just having a stool softener.
Yep.
And it's easier to adjust the doses by increasing the sachets. And I think the studies have shown that actually it is superior to lactulose.
Yeah. Fortunately, now in India we have polyethylene glycol sachet with or without electrolyte available. So it is not difficult to procure and use it. It is basically scientifically superior to lactulose. It doesn't get metabolized inside the tummy, so there is no risk of gas formation or pain, and so side effect is less. And this is the meta-analysis of 5 studies, though it is not in true sense meta-analysis. They have compared that 5 studies comparing the lactulose versus polyethylene in children, and 4 out of 5 said that statistically significant means more effect with polyethylene glycol than lactulose. Tolerability is equal, side effects are less with polyethylene glycol, especially pain and distension. And advantage of polyethylene glycol, you can use the same drug for disinfection and maintenance therapy. Karmarkar sir, just can you elaborate about this diet and toilet training? It's a big problem, isn't it?
Absolutely. As I said, I mean, I would not see a child if he's bottle fed unless the bottle is stopped for 15 days. I wouldn't entertain a family to discuss the problem with me. So what I mean to say is you can't overemphasize the role of diet. And predominantly most of these patients have dietary problems. They lack roughage, they are milk fed, they are on constipating diets, biscuits, chocolates and white bread and whatnot. So I think it's an enormous task to get them to be on a good, balanced, healthy diet. I mean, the whole family needs to be trained and spoken to about this. You don't want them sitting in front of the TV and munching whatever comes. That's very difficult because we do it ourselves. So to tell them not to do it is very difficult. But that's one, and toilet training. I mean, it's especially I think in urban India with busy lifestyle, toilet training is being grossly neglected in children. And especially in big cities, both parents working. Unlike the old times when you had joint families, large families, there used to be somebody to train you to sit on the potty every day at a fixed time. We find that that's very difficult nowadays. So I think these things have to be impressed.
Yes, sir. Especially just one line about toilet training. You just ask the parents to make the child sit immediately after a major meal, because we try to utilize this gastrocolic reflex. There are two types, early and late. So earlier one is stronger. So all of us have the